My name is Kjell Larsson. I'm a respiratory physician in Stockholm, Sweden. Today I will say something about the eosinophilic granulocyte in chronic obstructive pulmonary disease, COPD. Since decades, the eosinophilic granulocyte has attracted a lot of interest for respiratory diseases, mostly in asthma. But the last 5-6 years, also this cell has been very important in COPD, and I will say some words about why that is. A French group discovered already in the 90s that there was some COPD patients who responded with an increased FEV1 after having prednisolone orally, and the other group did not respond with an increased FEV1 at all on the steroid. And they also found that if they looked at the responders and the non-responders, there was a difference with regard to eosinophils. The responders had more eosinophils in the airways, and they have higher levels of ECP, eosinophilic cationic protein. This indicated clearly that there was an association between the response to steroids and the occurrence of eosinophils in the airways. In this slide, the distribution of eosinophils in the population is shown. As we can see, the mean value is 1 to 8 cells per microliter, and we have not a normal distribution here. There are some people who have very high levels of eosinophilia. If we look at different subgroups in this population, we can see that those who have high eosinophils, that is younger persons, that is asthmatic persons, we know that since many years, and also allergic persons with a positive skin prick test. But as you can see, also COPD is one of the groups who have higher eosinophils. And that is why this is so interesting today, that we have discovered that the COPD patients really have higher values, and that means something for the indication of treatment. And if you go further on and look at the differences here, we can see that blood eosinophilia shown in the left panel of this slide. You can see that asthma and COPD has about the same levels of blood eosinophils, while the healthy subjects, as you can see to the right, have lower levels. In the right panel, you can see the eosinophils in sputum in asthma and COPD and in healthy subjects. Again, we have higher levels both in asthma and COPD, indicating that the eosinophils in the airways are increased in COPD. It seems also clear that the eosinophils are related to the severity of the disease in COPD. In this slide, we can see to the right that the gold stage 3 and 4, that is the more severe case of COPD, have higher eosinophils than stage 1 and 2, which are the less severe cases, which we see to the left. Here we can see the distribution of eosinophilia in COPD. This is a retrospective analysis of 4,600 patients. And as you can see, we have an uneven distribution, and more than almost 80% of the patients have a level of eosinophils higher than 100 cells per microliter. If we look at the next limit, which we are using, that is 300 cells per microliter, and here we can see that 1 out of 5 COPD patients have eosinophils above 300 cells per microliter. When you measure eosinophils in the clinic, it's important to know that the eosinophils may vary over time. That means that the levels of eosinophils may be low at one visit and higher on the next visit. In this slide, you can see where they have put a limit of 2% of eosinophils in the blood. You can see to the left that a little bit more than 10% of all the COPD patients constantly have values below 2%. To the right, you can see that a little bit more than 1/3 of the patients constantly have values above 2%. And in the middle, you can see that half of the patients varies over time. Sometimes they have values below 2%, and sometimes they have values above 2%. That means that one single measurement where you can see that the levels of eosinophils are low is not reliable. You have to take it again, because the next measure or the third measure could show higher levels. There are a lot of factors that influence the eosinophils. Exacerbations is one of them. There are patients who have eosinophilia only during exacerbations. And they can have normal low values between exacerbations. The time of the testing, we have a diurnal variation of the eosinophils, which are highest in the middle of the night and lower in daytime. Also, if we take the sample directly after eating a meal, we can have a lower level of blood eosinophils. Also after exercise, a few hours after exercise, the eosinophils goes down. Medications may influence the levels of eosinophils in blood. We have the oral steroid, which depress the eosinophil level. Inhaled steroids don't, if you don't take very high doses. But in the regularly used doses, inhaled steroids do not influence blood eosinophils. One very important thing here is that the eosinophils are associated with the exacerbations. For the COPD patients, we have the two critical issues is symptoms as dyspnea and the exacerbations. The exacerbations are associated with lower quality of life, more rapid lung function decline, increased morbidity, and increased mortality, actually. So the exacerbations are critical for the patients with COPD. And we know that blood eosinophils are associated with this. And the higher eosinophils you have, the greater is the risk of exacerbations. We can see here, to the left, you have eosinophils below 130, and the bars to the right is increased blood eosinophils. And you can see on the y-axis the exacerbation rate. And the exacerbation rate increases with the numbers of blood eosinophils. Here again we can see the association between eosinophils and the rate of exacerbations. You can see 4 bars. To the left we had those patients with the lowest number of eosinophils, less than 2%. And the next bar is higher, and the most right bar is the highest level of eosinophils. And as you can see, the more eosinophils you have, the greater is the risk of having an exacerbation. This group of patients was treated with only a bronchodilator, that is, a medication that do not influence the eosinophils. Then you can use this because the eosinophils is also a marker of a response to steroids. And this gets me back to the first slide I showed. This French study who really showed that prednisolone increased FEV1 in a subgroup of the patients. And this was a group who had high eosinophils. And if we look here at it again, we can see in the same study as I showed previously, you have these blue bars, and you can see here the increase in eosinophils from the left to the right. You can see that the rate of exacerbation is the same because this group was treated with inhaled steroids. So eosinophils in the blood seems to be a good marker of the risk of exacerbations and is a good marker for the positive response to steroids. So if you compare those two groups, you can see the clear difference between if you are treated with steroids and not, and how that is associated with blood eosinophilia. In the next slide, you can see two big studies comparing triple therapy with double bronchodilation. That means that in triple therapy, you use anticholinergics, beta-2 agonists, and steroids. And double bronchodilation, you only use the bronchodilators, anticholinergics, and beta-2 agonists. And as you can see to the left, we have two different curves. The triple therapy is parallel with the x-axis, which means that the exacerbation rate does not increase with the number of eosinophils. You have eosinophils on the x-axis and exacerbation rate on the y-axis. Whereas you see the other curve, that LAMA plus LABA, is there you can see an increase in exacerbation rate with increased eosinophils. And you can also see here that if you are below 0.1 eosinophils, there are no difference of the exacerbation rate between the groups. Between 0.1 and 0.3, the curves start to go to different ways. And the difference between the groups starts to be greater. And above 0.3, you can really see a big difference in the exacerbation rate between the triple group and those who only get bronchodilators, indicating that the inhaled steroid really prevent exacerbations. In the right is another big study where you have two arms who are treated with ICS. You have ICS LABA and you have the triple. And you can again see that the exacerbation rate is not dependent at all on the eosinophilic count, while the group who are treated with only bronchodilators have an increased exacerbation rate with increased eosinophils. The assessment of eosinophils also have had an implication for the GOLD document. In that document, they say that there is a strong support for treatment with inhaled steroids if you have had a very severe exacerbation, so severe that it needed hospitalization. It's also a need for ICS if you have had 2 or more moderate exacerbations last year, if you have eosinophils above 300 cells per microliter, or if you have a history of, or if you have concomitant asthma. There, you should consider the use of inhaled steroids if you have had 1 moderate exacerbation in the last year, despite the fact that you are treated with double bronchodilation. Also, if you have blood eosinophils below 100 and 300 cells per microliter. So down to 100 cells per microliter, there may be an indication for steroids. However, there is argument against the use of inhaled steroids if you have repeated pneumonias, if you have blood eosinophils below 100, and that is probably that you should not at all treat patients who had so low eosinophils with steroids, and if you have a history of mycobacterial infections. So if we summarize the assessment of eosinophils in COPD, we can say that eosinophilia is a marker of increased risk of exacerbations. The higher the eosinophil count is, the greater is the risk of exacerbation in COPD. Eosinophilia is also a marker for positive response to inhaled steroids. If you have a high eosinophil level, you have a better chance to prevent exacerbations in COPD with inhaled steroids. It's also that eosinophilia may guide you when you withdraw ICS in COPD patients. If you have a COPD patient who haven't had any exacerbation in the last 2 or 3 years, you may consider to withdraw steroids. If that patient had high eosinophils in the blood, you should be careful, because then it may be that they have been free of exacerbations because of the treatment. If they have very low levels of eosinophils, you may be right in withdrawing the steroid. Blood eosinophil may vary over time, which means that you should not rely on one single measurement, which may be low. Perhaps you have to repeat that measure once or twice before you can say for sure that this patient really have low eosinophils. And lastly, blood eosinophils may improve your possibility to have a personalized approach to your COPD patient, because it can guide you for treatment and for the withdrawal or treatment. That was my final slide. Thank you so much for your attention and for listening to this.